Failure Program and Director of Clinical and Translational Research Office at the National Heart Centre, Singapore. He is the current President of the Heart Failure Society, Singapore, and Honorary International Advisor to the Hong Kong Heart Failure Society. His subspecialty interest is in heart failure, mechanical circulatory support, and heart transplantation. Prof. Sim also has an interest in palliative care for heart failure. He is the Project Director for the Advanced Care Planning Program in National Heart Centre, Singapore. Today, Professor Sim is talking to us about challenges in managing heart failure in a patient with renal failure. Over to Prof. Sim.
Thank you for the kind invitation to this conference. The lecture topic that given today is challenges in the management of heart failure in a patient with renal failure, a very common situation that we face in the real life situation. These are my declaration of interest. When I talk about heart failure, usually we can't run away talking about chronic kidney disease. The renal and cardiovascular disease are very closely interconnected. Acute or chronic disorder of one organ can result in disorder in the other organ. So you can see here the presence of diabetes, diabetic kidney disease, or other form of kidney disease usually will impact on the development of heart failure and vice versa. And the key thing is when a patient with heart failure also has CKD or renal impairment, it really makes the prognosis worse as well. And to make matter worse, in Asia Pacific region, you can see from this study, when they compare the heart failure registry from the Western cohort of patient, the heart failure action, and from an Asian heart failure registry, a heart failure registry from 10 different countries here in Asia, you can see that the prevalence of diabetes as a comorbidity in heart failure patient is much higher in the Asian patient. For example, in the Indian patient and Malay patient, much higher incidence of diabetes. And we know that diabetes is a major risk factor for development of not just heart failure, but also for kidney disease as well. So this cardiorenal syndrome is a real big issue here in Asia with a high prevalence of diabetes. And now let's switch gear to the management of heart failure with reduced ejection fraction. These are the latest guidelines I'm shown here from the Canadian guideline and from the latest recent ESC guideline. As you can see, there's a shift in the management strategy from previously a very sequential kind of approach where we try a few drugs, it doesn't work, then we add on a second or third line drug. But now the new approach is 4 first line drug. That is namely the RAS inhibition with either ACE inhibitor or ARNI, a beta blocker, a MRA, and an SGLT2 inhibitor for the initial treatment of patients with heart failure with reduced ejection fraction. As you can see here, some of the therapies such as ACE inhibitor, MRA, that have been around for many years, they do have an impact on the renal function. And the renal function can also influence on how willing are we going to use all this drug. And then we have also newer drug that I'll touch on later in the lecture. So first, let's talk about ACE and ARB. As you can see here, from the ESC guideline, there's a caution in using it in patients with significant hyperkalemia and patients with significant renal dysfunction taken as a eGFR of less than 30. The color of 30, I guess, is mainly because of most of the heart failure drug, the inclusion criteria was taken as an eGFR of 30 mils per minute. So it's not that we can't use this drug, but just that in those patients with significant renal impairment, less than 30, we have to use caution. And the same apply to the MRA, where significant hyperkalemia and significant renal dysfunction, we have to use a drug with caution. Now back to the guideline, now showing you the Canadian guideline as example. You can see that we have moved beyond ACE inhibitor and beta blocker MRA when newer agents such as ARNI, SGLT2 inhibitor, and also vericiguat for the treatment of heart failure. So the first agent that I'm going to touch on is ARNI, and I'm going to discuss how it impacts on the renal impairment. As we know, the ARNI is a class of drug, a combination of sacubitril and valsartan, and the first trial that looked at it in a phase 3 big trial was that of the PARADIGM-HF in a chronic heart failure setting in patients with reduced ejection fraction. sacubitril valsartan was compared to enalapril. And in chronic heart failure patient, it was found that the use of sacubitril valsartan was associated with a decrease in cardiovascular death or heart failure hospitalization. Importantly, when it comes to the safety profile for the renal function, in terms of elevated serum creatinine of more than or equal to 2.5 milligram per deciliter, it was statistically significant in terms of lower incidence in the patient taking sacubitril valsartan. At the same time, those with elevated serum creatinine of more than 3 milligram per deciliter, you can see numerically it was lower in the group taking sacubitril valsartan, though the p-value is not significant. And you can see in the serum potassium as well, less likely to develop hyperkalemia with the use of sacubitril valsartan compared to enalapril. Now moving on to the next class of agent, the SGLT2 inhibitors, which have gained a lot of interest in the last couple of years. First started off as a type 2 diabetes drug, and then now they move on to use the drug in heart failure and renal impairment as well. The two trials for reduced ejection fraction was the EMPEROR Reduce and the DAPA-HF, also in chronic heart failure patient with ejection fraction less than 40%. But do take note, the eGFR cutoff, it was 30 mL per minute for the DAPA-HF, very similar to previous heart failure trial. But for the EMPEROR Reduce, the eGFR was lower all the way down to 20 mL per minute. This has important implication because it allowed more patients with more advanced CKD to be included in the heart failure trial so that more CKD patients can actually benefit from heart failure treatment. And as we know, the dapagliflozin used in heart failure with reduced ejection fraction was associated with a 26% relative risk reduction in the primary endpoint of heart failure, hospitalization, or cardiovascular death. Very, very closely mirror that of dapagliflozin was empagliflozin, where the relative risk reduction was 25% as well. So in terms of renal outcome safety profile with the use of this class of drug, you can see that in terms of renal serious adverse event or serious kidney injury, acute kidney injury as reported by investigator, the use of dapagliflozin when compared to placebo was actually associated with a lower incidence of the renal adverse event. Similarly, in the empagliflozin trial, in the EMPEROR Reduce, you can see that the use of the SGLT2 inhibitor, at the beginning, there was an acute drop in the eGFR that is expected for this class of agent. Just like when we use ACE inhibitor, we expect an initial drop in the eGFR, but this can be accepted because we know that in the long run, there is a slowdown in the decline of the eGFR. As you can see, the slope was more gradual in terms of the decline of the eGFR for the group taking empagliflozin, so that at the end of the study, the group taking empagliflozin had a higher eGFR compared to those patients taking placebo. And this was translated to a reduction in the composite renal endpoint of end-stage kidney disease or sustained profound decrease in the eGFR as well. Similarly, in patients with preserved ejection fraction, we have now the EMPEROR Preserve result that show that the use of empagliflozin, the SGLT2 inhibitor, in this group of patients with ejection fraction more than 40%, also just similarly like the reduced patient, show a slowing down in the decline in the kidney function as shown here, a decline in the eGFR. The decline in eGFR was lower than those patients taking placebo. And not only is the renal protective effect and the cardioprotective effect of the SGLT2 inhibitor demonstrated in heart failure trial, in the CKD trial, the use of dapagliflozin was also being studied. So it was a comparison of dapagliflozin versus placebo in the setting of CKD patient with an eGFR between 25 to 75. The primary outcome was a renal outcome of sustained GFR decline, end-stage renal failure, renal or cardiovascular death, and with a secondary endpoint of composite of cardiovascular death or heart failure hospitalization. And of course, we know that from the DAPA-CKD, the use of dapagliflozin was associated with a decrease in the primary endpoint of the renal outcome by 39%. Importantly, in the CKD patient, the use of SGLT2 inhibitor was also associated with a decrease in the cardiac outcome of cardiovascular death or heart failure hospitalization. So now I move on to another agent, vericiguat, which is a direct cerebral guanide cyclase stimulator that result in the increase in the cyclic GMP. As you can see, increase in cyclic GMP in heart failure patient will result in less fibrosis, less ventricular remodeling, increase in vasodilatation, and increase in renal blood flow, all the effect that we want in somebody with heart failure. And that was studied in the Victoria trial in the setting of heart failure reduced ejection fraction as well after a recent heart failure event. What is important to note here is the eGFR cutoff for the Victoria trial was as low as 15 mils per minute. So that even allowed more CKD patients, more advanced CKD patients to be recruited into a heart failure trial. And like the previous two agents that I have described, vericiguat also significantly reduced the primary composite endpoint cardiovascular death or first heart failure hospitalization. And importantly, if you look at the subgroup analysis in terms of eGFR at baseline, regardless of whether eGFR is more than 60 or in the group with the lowest eGFR less than 30, it all works for this group of patients. The benefit of vericiguat apply to all the different eGFR. And importantly, the use of this agent did not change the eGFR over time when compared to placebo, and also no statistical significance when compared to placebo in creatinine change over time. So now I'm going to switch to another issue, not so much talking about eGFR, but more about hyperkalemia, which is quite common in patients with heart failure and with CKD. And when they have a combination of CKD and heart failure, it is even more common to have hyperkalemia. And the important thing to note is hyperkalemia is not a one-off event. It is usually recurrent, and the time interval will decrease between each episode. So it can be a very problematic problem for us in the use of heart failure drug in this class of patient. Of course, we know hyperkalemia causes an increase in all-cause mortality, result in CKD progression, and result in an increase in all-cause hospitalization with an increased healthcare burden and cost as well. So what are current hyperkalemia treatment options that we have for patients? Obviously, low potassium diet, the use of diuretic help as well. But usually, even with these two strategies, some patients will still have significant hyperkalemia. Obviously, stopping or reduction of the RAS inhibition is not a good approach which we try to avoid. And there are some traditional potassium binder, but the problem is they cause a lot of GI side effect, and the taste can be very unpleasant to some patients. So I mentioned the use of the strategy of stopping the RAS inhibition or reducing the dose of RAS inhibition is to be avoided, because as we know, by reducing or stopping the RAS inhibition, it results in a higher mortality in both heart failure patient and CKD patient as well. Some of the strategy that we can use is in the selection of drug for heart failure. For example, for the RAS inhibition, we can actually use a ARNI compared to an ACE inhibitor. With the combination with MRA, the use of ARNI is less likely to cause hyperkalemia compared to the combination of ACE inhibitor in April with MRA. Similarly, in those patients who were started MRA later, that means they were started on ACE inhibitor first or ARNI, and subsequently when MRA, we also find that the use of ARNI with additional MRA later was associated with a less incident of hyperkalemia compared to ACE inhibitor with a later additional MRA. And lastly, we do have also now novel potassium binder as shown here, patrimonial and sodium zirconate. These agents are more palatable, unlike the traditional potassium binder, which are unpleasant taste. So that may also help with the usage of the RAS inhibition with MRA in our patient, so that rather than stopping the drug, all these novel potassium binder can help us to increase the usage and up-titrate the dose of the RAS inhibitor, which we know is very important in the treatment of not just heart failure, but they have also renal protective effect as well. So to summarize, the cardiorenal syndrome or the combination of heart failure and kidney impairment is very common. In fact, here in Asia, we do have a big issue of diabetes as well. So that adds to our problem as well. So when I look at the heart failure, kidney failure, and diabetes, I see them as a triad, like closely in the marriage, tied bind up together. So, but we do have many different choices of drug, and we use appropriately with caution. Most of these patients can still have the cardioprotective effect of most of the drug. Thank you for your attention.
Thank you, Professor Sim, for your fantastic talk and giving us a good overview of these commonly coexistent conditions. And in the interest of time, we can allow one burning question from the audience.
Professor David, it was very interesting and thanks for your presentation. And I would like to ask you, particularly with the kidney disease and heart disease, now there is recent evidence for GLP-1 receptor agonist with the trials of leaders and sustain. And would you think that in a low GFR, when you compare with the SGLT2 inhibitors and GLP-1 receptors agonist, and do you think there is a place of GLP-1 receptor agonist adding into the heart failure management with renal disease?
The simple answer is we don't have study particularly looking at heart failure with GLP-1 agonists. The study so far has been the use of SGLT2 inhibitor, as a diabetic drug. Now it has been extended to kidney and heart failure as well. So until we do a formal trial of GLP-1 in the heart failure setting, I think we will not have an answer. So GLP-1 now is still mainly limited to diabetic patients. I know it's also used for obesity management as well. But particularly in a non-diabetic patient, if we want to use GLP-1, that probably will need to be studied in the future trial because we really just don't have good evidence and data, big phase 3 trial for that. Yeah. And maybe I'll just add something. I think previously there was a question to Professor Rosano on the use of SGLT2 in the acute setting. I just want to bring to everybody attention, during the recent AHA, I think about a week ago, there was a new trial, the MPulse trial, with the use of Jardiance SGLT2 inhibitor in the setting of acute heart failure. So now acute heart failure, we can use SGLT2 safely as well, as shown by the trial, the MPulse trial.
Thank you very much, Professor Sim. So time allocated for this symposium is over now. So we have to stop this our symposium here. So I would like to thank Professor Rosano and Professor David Sim for the excellent presentation on behalf of Ceylon College of Cardiology. Thank you very much.